Hi everybody, today we're talking about a bit more about indications for PBMT, and we're going to be covering this from the lower limb but also broader health and medicine in general, because I think it's really important that we start to get an understanding, if we are maybe podiatrists, that there are other parts on the body that might be in pain, and if we are needing to sort of handball that onto one of our colleagues, whether they're a chiropractor, physiotherapist, nurse, massage therapist, one of our doctors, that they may be able to undertake PBMD to help that and better service our community more holistically in that way. But when we start looking towards the forefoot, we start thinking sort of sesamoiditis and that first MTBJ pain, the capsulitis, the effusions, start moving a bit more lateral and start talking to our Morton's neuromas and whether we want to reduce sort of some of the inflammation around that and decrease the pain. Of course we do. Our plantar plate pathologies, our metatarsalgia, which sort of encompasses a lot of what's happening there, but it is good as a therapy because even without a clear diagnosis, we can make sure that we're on the right track and ensuring that our patients are going to decrease pain and get better faster. Start talking about bursitis, our arthritis, and we're not really going to change sort of the bone structure, but we are going to calm down any degenerative processes there and really help to decrease the pain associated with capsulitis and effusions, along with those hallux valgus, bunion deformities, claw and hammer toes, and that side of things. Freiberg's disease, another fantastic one, osteonecrosis of the second metatarsal head here, that is going to be relieved because we're slowing down that traumatic process and increasing that healing so that our threshold of pain is higher and we're not as likely to get any pain associated with it. Really important. As we get to our rear foot, our tendinopathies, and Achilles tendinopathy in particular has got a fantastic base of research there that really enables us to know that we're evidence-based and we're giving the best outcomes along with our eccentric strengthening, plus or minus some shockwave, and putting things into place that are going to get our patients better quicker. But of course, a tendon's a tendon. So whether it's the posterior tibialis, anterior tibialis, our peroneals, or whether it's a tennis elbow, these are all tendon concerns that we can start to potentially help there as well. A plantar heel pain syndrome, and I sort of look at this as from a syndrome point of view now, where it's not just our plantar fasciitis, plantar fasciopathy, but also our plantar, our plantar fat pad inflammation, our calcaneal edema, a Baxter's nerve entrapment, tarsal tunnel syndrome, tibial nerve compression, medial and lateral calcaneal nerves potentially entrapped as well. And so looking at all of these, this is a great spot that laser therapies can help with. And then we start looking at our ganglions. Again, this comes into sort of our space occupying lesions where we want to reduce the pressure from these to decrease our pain. Again, PBMT can be a good option there. Our ankle sprains, of course, ligaments are going to be injured, there's going to be swelling. Another good spot there, tarsal tunnel syndrome. This is something that is caused by our ganglions, our space occupying lesions, whether that's off the flexor hallucis longus or whether that might be due to a varicosity. And that's something that we can definitely keep in mind. Our coalitions, whether that is the connection of our subtalar joint, whether that might be a talar navicular coalition, all these sort of things we then start to consider as well. Then we go into our Sever's disease, our calcaneal apophysitis, this is going to be really helpful, but of course, thinking again, maybe treating bilateral, which we've got a little bit more information on in our contraindication slides. But then, ligaments, it doesn't matter where, it's going to help decrease, the swelling around them and increase the repair, ensuring that we are going to maintain that proprioception that we get a lot. As we're going up to that knee and the lower leg, do consider our lymphedema. It's such a great body of research and great outcomes that we're getting in clinic when it comes to any swelling concern, whether it is venous insufficiency or lymph post-traumatic related. Our compartment syndromes, particularly those activity-induced or chronic compartment syndromes, we just find that we can relax those muscles so much easier and get such good outcomes, avoiding that potential for a fasciotomy to be undertaken surgically. Lymphedema again, because it just works so well. The sciatica, not only from that lower back, but if that's coming down through to the legs and feet, we need to be thinking, okay, well, let's treat proximally, but then let's look a bit more distally as well. freeing up any contractions that are occurring, reducing some of that burden around the joints and releasing anything that does need to be undertaken there. Our Osgood Slatters, similar there to our severs, going to be providing great outcomes. A medial tibial stress syndrome, or shin splints for those not as medically determined, looking at the terminology, a great way to relieve some of our pain. Our Baker's cysts, and whilst we're behind the knee, really think about that lymphatic. And here we are talking about lymph again, but it is such a good spot behind the knee in that popliteal fossa where we have our lymph, nodules there, able to start bringing up that. Think about our inguinal glands as well, where we're going to be able to start moving that lymph and drain that lower limb a little bit more effectively. And of course, if we've got a cold, using it around the neck too, making sure that we're giving our patients the best chance for a recovery. The ACL injuries of the knee there. But then if we start looking whole body, we start thinking about that sciatica and low back pain that I mentioned. We start talking about burns healing, osteoarthritis, inflammatory arthritises, whether they are rheumatic, psoriatic, gout, diabetes, looking at the trigger points and releasing structures that way. It's a lot quicker, a lot easier, and patients like it a lot more than acupuncture or dry needling, I'll tell you that. But then our fractures, our breaks, and our post-surgical healing for myself, fantastic. Wound healing, diabetic wounds, up to 300% increased healing rate. I love those systematic reviews coming through. That surgical wound healing and edema reduction, top notch. That post-injury edema, ankle sprains, getting caught trauma, hematomas that way, really important. Our COVID-19, looking at an x-ray here, there's definitely some fluid on the lung there that's causing concern, some adhesions. And that long COVID, we're finding some great research coming through. Our pain syndromes, CRPS, fibromyalgia, our peripheral neuropathies, and really having a bit of a look at these. And a lot of the questions I've been getting lately are really around, okay, well, what's the cause, so that we make sure that we're dealing with that. So if it's diabetes, our blood glucose levels need to be, perfect, and be managing that to reduce that potential that we're, getting worse. Okay, if it's B12, looking at our, or B12 insufficiency, we need to be looking at our supplements, our injections. If it's chemotherapy induced, the sooner we can put it into place for all of these, the better, but particularly with chemotherapy. If it's alcoholism, we need to stop that, but then we need to repair it. And these are long-term disease processes that are occurring from long-term consumption potentially. It's going to be difficult to say to that patient, we're going to be able to heal that with just a few sessions. But any musculoskeletal pain, injury and dysfunction, that's pretty much all of our patients coming through. So we need to be thinking about these type of things. But oral mucositis, lymphedema again, because I really think it's so effective there. Our wound healing, chronic and acute, surgical, neuropathic pain, and of course all of our nerve entrapments, of which there are many, it can really help out here. But then we start going into our orthodontics and, a temporomandibular joint dysfunction. And I know a lot of maxillofacial surgeons and dentists that are saying, okay, well, let's go do a course of laser first because it works. And that's pretty much what they'll put into place, a bit of strengthening, maybe release, but the laser therapy is really pushing that area. That age-related macular degeneration, to the point where they now have some devices that you just put your head into and it will do those eyes, fantastic. The burns healing, the tinnitus, vertigo, we get great results there. The rhinosinusitis, the trigeminal neuralgia, the hematomas, the migraines and the headaches, something that we've been getting great results for here. All of these sort of things can be really effectively treated. And I think it's really important that you know of the different ways that we can potentially help our patients, so that we can implement that into practice, make sure that we're getting the best potential for our patients, and providing them with that holistic care. And if you can't do it within the clinic, then realising the limitations of your scope or your knowledge and referring out as appropriate, I think is really important. But every condition can potentially be treated with PBMT. There's a few things to check with the contraindications, which we'll be talking about next. But don't just think feet, think the whole body. Think about that tendon as a tendon. Think about that, healing is healing and regeneration, and knowing how this laser therapy, PBMT, works is the first start there. But today, this has been Indications for PBMT, and we'll see you on the next session. Cheers.